Okay, hello. We are going to have our last session today. The first speaker for the last session is Dr. Joseph McBride. He is Associate Professor, Chief of Interventional Radiology Department. He is going to give us a talk on Y90. Welcome.
Thank you. So first, for disclosures, I'm a consultant for a company called Integer Corporation. They make wires for pacemakers and for angiograms, but really nothing to do with this product that the products we'll be talking about today. Just a little bit of background, which I'm sure you're all aware. The hepatocellular carcinoma, the sixth most common cancer worldwide, fourth leading cause of cancer-related death. Risk factors are viral hepatitis, ethanol abuse, and non-alcoholic fatty liver disease. Early stage resection, liver transplant, and ablation technologies. Intermediate stage has traditionally been chemoembolization, radioembolization, advanced systemic therapy. And you'll be talking about SBRT as well. What is Y90? It's a beta emitting radioisotope of yttrium, has a half-life of 64.1 hours. That's a very short tissue penetration, just 2.5 millimeters and 11 millimeters maximum. After treatment, a lot of the patients say, do I need to be away from people? And everyone is released to the public. Some patients can set off radiation detection at international airports, so we do give them a travel letter if they're going to travel. We deliver this via the arterial circulation. There's preferential uptake by the tumor vasculature, particularly in hepatocellular carcinoma, just because it tends to be a very hypervascular tumor. And we give a local high dose radiation with minimal systemic effects. The ideal candidates have unresectable liver cancer, have good liver function with Child-Pugh A or B7, ECOG status of 0 to 2, and no extra hepatic disease. Contraindications: excessive tumor burden, limited healthy liver, patients with severe liver dysfunction. Do we do a cutoff of a bilirubin of 2.5 to 3, unless they have Gilbert's? Significant extrahepatic disease, and patients with significant arteriovenous shunting on angiography. So overview, when we talk to the patients, I usually call this a rehearsal angiogram, or and for purpose of scheduling, we call it a mapping angiogram. And this is where we look at all of the hepatic arterial anatomy, and we particularly look for any hepatic arteries that might give rise to gastric arteries. So sometimes there's a right gastric artery that will come off a right hepatic artery. And there can be other variants as well that we look for. Sometimes there's arteries that go to the falciform ligament, so we have to be kind of careful with that. If we do specific, if we have a very large treatment volume, the shunt can be low, and that could still cause a result in a high dose to the lungs. And also you could have a small tumor, but with a huge shunt, and that may or may not, being that if it's such a small area, it may not be a consequence, that even if 40% of the dose goes to the lungs, it still wouldn't be a very high lung dose. Maximum lung dose for each treatment is 30 gray, and that tumor can change. We try to get as selective as we can into the targeted hepatic arteries. We administer the microspheres, and then we do have the option of performing a SPECT CT or PET CT afterwards to verify that our dose went to the area we intended it to go to. There's two types of Y90 microspheres, and originally TheraSphere came out as a product that was approved with less than 4,000 patients a year initially, so it required an IRB. They since have gotten full FDA approval, so we don't need the IRB anymore. But the TheraSphere glass microspheres have a much higher activity of radiation per sphere. So about 2,500 becquerels per sphere. Is that you can use it in portal vein thrombosis. You're technically embolizing since you're putting particles into the arterial stream, but there's so few particles that there still is arterial flow after. So if there's a portal vein thrombus, either bland or tumor thrombus, you can still safely give TheraSphere in a patient with portal vein thrombosis, but TheraSpheres are generally contraindicated as chemoembolization would be in patients with portal vein thrombosis. In studies specific for portal vein thrombosis, median survival 10 to 13 months and a few studies, and there's a potential for downstaging to transplant in some select cases. There's different approaches to dosimetry with Y90. Often body surface area or the standard absorbed dose to the treated liver. Often it's 120 gray to the treated liver volume for glass or microspheres. Personalized dosimetry is tailored to the individual patient and the tumor characteristics. We might use 3D imaging, sophisticated dose calculation algorithms, and we try to deliver the optimum dose to the tumor while sparing healthy liver. And there's various models that we'll use to calculate those doses. Here's an example: a patient with a hypervascular colorectal cancer, and this patient had already had a right lobectomy. This lesion was very close to the heart. He had talked to Mayo about doing proton beam, and then Mayo kind of wanted to wait 6 months before they did anything. I did his angiogram, and it was for a colorectal. And by selecting, so here's the angiogram where we have a couple hypervascular lesions in the liver here. And by doing the cone beam CT, we do an arterial ejection while we're doing a CT. And then we can pick a region of interest on our cone beam CT, and we put it through a computer software It's called EMBO Guide, and the computer will pick out the most likely arteries that are supplying the tumor. And then we can target our dose to get as close as we can to tumor only, so that we can, there was actually two vessels that were supplying this. There was this tumor, this lesion has both a left hepatic artery and a right hepatic artery supply. Some of the evidence for our clinical data for Y90. The Dosifir trial came out in 2021. 56 patients with locally advanced or inoperable HCC. Did personal dosimetry versus standard dosimetry. Standardized arm got 120 plus or minus 20 to the treated volume, and the personalized arm got at least 205 gray. Primary outcome was tumor rate, response rate at 3 months. Personalized had a 71% response rate, where the standard had about half that. The median overall survival was 26.6 months in the personalized and 10.7 in the standard, with a conclusion that personalized dosimetry significantly improves patient outcomes. The Legacy study was a retrospective single-arm study with 162 patients with early and advanced. Again, it was a TheraSphere study out of Northwestern. The objective response rate was 88%, median overall survival 65, 3 years, 86.6, and the transplant resection rate was 31%. Conclusion of that study was that Y90 showed high response rates and promising survival outcomes in both early and advanced hepatocellular carcinoma. Premier study, again, out of Northwestern, randomized prospective study with 45 patients. They compared Y90 versus conventional TACE. I'm not sure that we don't do conventional TACE anymore, but we do drug-eluting beads. And I think even with the cone beam CT, the drug-eluting beads would probably be better than traditionally when doing low bar treatments. But the median time to progression, 26 months for the Y90 group and 6.8 for the TACE with conventional TACE. And the median overall survival for Y90 was not reached, but the conventional TACE was 18.5 months. Conclusion was that Y90 had superior time to progression compared to conventional TACE. So the treatment algorithm, it's a multidisciplinary approach. You can use it as a bridge to transplant, use it to downstage an alternative to chemoembolization in patients with intermittent hepatocellular carcinoma, potential first-line therapy in some patients, and then there's potential for a combination with systemic therapies in advanced cancer. Future directions, ongoing research, combination with immunotherapy. For the refinement with the personalized dosimetry, some of the software programs we're talking about purchasing have the ability to calculate the dose a little more accurately. There's novel microsphere technologies, and there's other companies coming into where we can actually order a specific number of particles and how much radiation we want, potentially, and expanding indications, early stage ACC and also metastatic liver disease, which we're already doing some. So it's an effective local regional therapy across various stages of hepatocellular carcinoma. Has comparable survival outcomes and better quality of life and safety profile compared to some of our, at least compared to conventional TACE. The personalized dosimetry shows promise. There's a potential for combination strategies, and their ongoing research might further expand indications. Thanks.
Okay, so I have no conflict of interest. response rates. We will also explore factors associated with local control and survival and SBRT associated toxicities. And I also present the SBRT versus radio frequency ablation, a comparison of these two. And then we will get into SBRT for recurrent HCC. And finally, we'll talk a little bit about SBRT as a bridging therapy for liver transplant. So this patient I treated 10 years ago. You can see that he has very big lesion in the center of the liver. The most left one was the axial. Okay, so in our hospital, the normal AFP is 35 or under. So you can see that after 2 courses is going under. So this patient actually, the left upper panel, you can ago, he came back to do the 10 years, we still see no cancers there. And this patient actually has a very interesting story. Initially, he wasn't the surgical candidate, wasn't the transplant candidate, so they just sent to me for palliation. And then after he finished radiation, everything's gone. They said, can we do transplant? And they actually got located the liver for him. He was going to do the transplant. That day, he backed out. He said, no, I'm not going to do it. So he's still alive and well right now. This is a second patient. Again, the tumor is so big that I couldn't do 50 in 5. Again, I did the 25 in 5, but now actually we usually do the SIB. So in the center of the lesion, I escalate to the 40 gray in 5. And you can see that this patient initial ALP was 6,900 something. And then after the treatment, I was going to do another course, but then everything back to normal in 3 months, 32.8. And you can see that the lesion also, the tumor become necrosis. You can see the necrosis in the center of the disease. It's like become black, and also the cavity becomes smaller and 10 months after that. And the third patient, that the tumor was pretty small, so I was able, although I say small, it's actually 5 centimeters. So I did the 50 gray in 5 fractions. You can see that the tumor actually initially was heterogeneous, and then by the end it become black. I think it's also necrosis, and this patient is only 14 months post SBRT. Okay, so let's look at the Astro clinical practice guidelines and radiation doses. We have this ultra hypofractionation, moderate hypofractionation, and standard fractionation. Outcome of SBRT in HCC is local control. Most of the studies showing that local control is about 75 to 95%. And in this study, actually, the 1, 2, 3 years actual local control were 93, 89, and 86%. And more importantly, they look at the patients who had the BET 10 of over 100 gray versus those 100 or less, and there's no local control difference. When we do SBRT, we usually look at the radiological response. If the patient, going for surgery or transplant, and we also look at the pathological response. And these patients, they received a BED10 of 47.6 gray to 100.8 gray. And you can see that the complete radiological response is about 30%. Pathological complete response is 14%, which is much lower. But partial radiological response is 7%, partial pathological response was higher, was 23%. Very interesting thing is that if you look at the CR plus PR, radiological responders and the pathological responders, they both are 37%. So although we all know that SBRT has a very high local control rate, but it's not that without challenges. So we can see the local failure rate. We can see the local failure, including the infield liver failure and out-of-field liver failure, and also distant metastasis. In this study, we see the infield fail is only 9.5%, but outside of field in the liver failure is double, the 21.4%, meaning, HCC usually is metastasis or with the initial large tumor, and they have worse survival. This study is another study looking at the factors affected the overall survival of HCC patient. You can see that Child-Pugh scores apparently affect the overall survival. Child-Pugh A is better than B. Less than 53.1 gray. Another factor in this study showed that it's a tumor thrombosis. Tumor thrombosis also a negative factor associated with the overall survival. And they also look at the local control rate that's affected by the dose that the patient received. Less than 30 gray is worse than the over 30 gray. We do have a lot of data on Child-Pugh A patients. They usually, we have a toxicity and efficacy, but we have limited data on Child-Pugh B. We don't have any data on Child-Pugh C because they usually have very bad outcome. So I don't do SBRT on Child-Pugh C. So that usually is my first question when they ask me, can you do that? I ask them what's a Child-Pugh C. I said, no, I don't do it. So you can see that Child-Pugh A usually has a better outcome, better overall survival, better progression-free survival. And that could be also because we usually give less dose to Child-Pugh B patient because they have underlying liver disease, and we want to cut down the toxicity. Recurrent HCC is a challenge. Usually they have treated underlying liver disease, and so SBRT is very precise and has advantage of we can do the radiation to the treated area without added toxicity. So that's why in this study, actually, you can see that those patients received SBRT again, they do much better than those who did not receive the SBRT. The same risk of ILD, but what we need to do is that if you want to treat a bigger area, then you have to give a less dose. If you want to give a higher dose, you have to radiate less volume. So in this study, you can see that every patient received the 24 to 54 gray in 6 fractions, and they do see that a grade 3 toxicity is about 26.5%, grade 4 is 2.9%, grade 5 6.9%. Among those grade 5, 7 patients, 5 patients died from liver failure, and the other 2, one is cholangitis, one is gastritis, GI bleed. For grade 4, we have 2 patients because of increased bilirubin and 1 also liver failure. So liver failure is the main thing. And in this study, patients received the 30 to 39 grade in 3 fractions, and we actually only have 1 patient had a late grade 4 toxicity, which is also liver failure. And this study, actually, they did a very interesting comparison. They look at the changes in common toxicity criteria grade, and they compare the pre-SBRT grade to the post-SBRT grade. What we see here is that the liver enzyme, no change in 46 out of 60 patients, albumin no change in 43 out of 60 patients, and platelets no change in 40 out of 60 patients, INR 50 out of 60, no change. Alkaline phosphatase, 53 out of 60, no change, and bilirubin, 31 out of 60, no change. So most of the patients still has no change. And in this study, they look at the complication probability as a function of a mean liver dose in 6 fractions. And they compare the Child-Pugh A5 to Child-Pugh A6. You can see that Child-Pugh A6 is just 1 score more. Also, the higher the dose to the 800 cc has a worse toxicity. And this piece of information also very interesting. The patients, they are all having the Child-Pugh A5, and you can see that if the patient has both a high mean liver dose and high D800 cc dose, then it will be the right lower corner, so they will have the highest toxicity rate. And now I just want to do a very brief comparison, want to present this piece of data that we all know that SBRT and radiofrequency ablation both can have lower part of 95% CI is cluster 1 when the tumor is smaller than 2. So that means, again, that means that if the tumor is smaller than 2, that there's no difference between these two regimen. And then the right side, they did a multivariate analysis. They corrected this comparison with the age, tumor size, and Child-Pugh score, AFP, and number of prior treatments, and they still see that in this specific study that RFA is worse than SBRT. Finally, I would like to briefly go through the SBRT as a bridge therapy in the transplant. Nowadays, actually, more and more SBRT is increasingly used as a bridge therapy for patients who's waiting for the liver transplant. And in this study, actually, you can see that everybody getting 50 gray in 10 fractions. And right now, we actually do more 50 gray in 5 fractions. But even with that 50 gray in 10 fraction, if you look at the rightmost, you can see that percent on necrosis. 2 patients has a complete response, 100%, and 2 patients has 0, basically not working at all, and then the rest of it in between. And this is another study that's showing also similar situation, and all the patients that received a 33 gray to 54 gray in 3 fractions. And you can see 3 patients had complete response. They all received a 54 gray in 3 fractions, and they all waited less time, like a 38 to 67 days. And then if we look at the right upper toxicity data, you can see that there's no patient with grade 3 to 5 toxicity. Finally, and this piece of data just try to show that those patients receive the SBRT, if they do transplant, of course, they have a better overall survival and progression-free survival. Now let me introduce Dr. Krishnan, and she is an assistant professor from the Division of Hematology Oncology, Department of Internal Medicine. And she's going to give us a talk on the immunotherapy combined with local therapy.
So I'm going to be talking about a little bit about the systemic therapy for HCC, and then kind of what's new on the realm or on the front for combination strategies with immunotherapy, as well as some targeted treatments that we've kind of had a lot of studies that have been mostly negative for. So okay, I don't have any disclosures. So objectives for my talk, overview of treatment of unresectable HCC, a little bit about systemic therapy landscape in HCC, and then we'll discuss a couple of recent updates on combined approaches with local therapy, especially immunotherapy. Again, reiterating that this is a kind of 3rd leading cause of cancer-related death globally, and it's the most common primary liver cancer. We know the pathogenesis arises in the background of chronic liver disease as a result of viral hepatitis, alcohol, or NASH. Unfortunately, one of the lowest 5-year survival rates at 21%, and typically challenges that we worry about or we kind of think about when it comes to management. Tumor burden, underlying liver function, and then comorbidities and performance status. So obviously we've kind of discussed a little bit about pathogenesis, but what I'm going to focus on today is kind of the immunosuppressive environment of HCC that makes it an important kind of target with these immunotherapies that have been recently approved for this disease. So we've already briefly talked about overall like treatment landscape. This includes broadly surgical options that include resection, transplant, systemic therapies that include immune checkpoint inhibitors or targeted therapies, and then we've already touched on local therapies. So these are the NCCN guidelines, the 2024 version for HCC, that essentially unresectable disease that are deemed ineligible for transplant. Things that you need to consider are underlying hepatic reserve, where the tumor is located, and what is the extent of disease. And based on that, treatment varies. It can be either local therapy or local regional therapy that includes ablation, arterial-directed therapies, or radiation. And then if they're not candidates for local regional therapy, then typically we think about a clinical trial or systemic therapy. And based on their underlying hepatic reserve, they may be not candidates for either of the above and probably require best supportive care. Since 2020, the standard of care for systemic therapy has changed. And these kind of two large randomized control studies that led to the approval of these combined therapies for first-line HCC. So in 2020, this combination was approved, essentially atezolizumab, which is an anti-PD-L1 inhibitor, as well as bevacizumab, which is the anti-VEGF or VEGF antibody, was approved in 2020 based on this study called the Empower 150 study that showed a pretty significant overall survival benefit over sorafenib alone, which was the standard of care first-line therapy, systemic therapy for decades and decades in HCC. And then moving on to this other study that was a Himalaya study that led to this approval of a combination immunotherapy regimen of dual immune checkpoint inhibitor, including durvalumab, which is an anti-PD-L1 antibody, and tremelimumab, which is an anti-CTLA-4 inhibitor. And this STRIDE regimen, it's also called the STRIDE regimen, led to the approval of study led to the approval of the STRIDE regimen due to the these patients kind of plateau, if they do end up having a response to treatment, then they can sometimes have even a durable response. So you can see the tail of the curve over there. How do we choose first line? So we have these two really good options for treatment, the combined immunotherapy, or we combine immunotherapy with an anti-VEGF, that is bevacizumab. So obviously we think about the workup that needs to be done and underlying Child-Pugh score. So both these therapies have been approved for only Child-Pugh A disease. How do we optimize the atezolizumab, bevacizumab? We always need an endoscopy before starting this treatment. So there's risk of bleeding with the anti-VEGF. So we think about getting an EGD at baseline. And then sometimes we use prophylactic beta blockers also. And then the other important thing to think about is any recent bleeding, thrombosis, or active wounds that might affect treatment with bevacizumab. And then when we think about subsequent line therapy, how do we choose what we use next line after they progress on first line immunotherapy? There's really no comparative data to define optimal sequencing of these agents after first-line systemic therapy. So we have many targeted therapies that are available now in the subsequent line setting. And some of these are sorafenib, lenvatinib that have been around for a little while. The kind of newer ones are cabozantinib, regorafenib, and there's also ramucirumab. And then checkpoint inhibitors, there are multiple other ones that have been approved for HCC when these patients don't receive, if for some reason they haven't received checkpoint inhibitor in the first line, then nivolumab, pembrolizumab, or a combination of nivolumab and ipilimumab is also approved. What kind of do we encounter with immunotherapy alone? I think the biggest impact is that its response rates are only moderate. And these patients eventually develop immune tolerance in the tumor microenvironment, and then they develop resistance to the immunotherapies. And then, so that's why we kind of come to this topic of combination therapies for HCC, and the rationale is essentially providing synergy and overall median progression-free survival for patients treated alone with chemoembolization remains about 7 to 8 months. So TACE also may prime the tumor microenvironment for immunotherapy via neoantigen release and ischemia. And then immunogenic cell death induced by local therapies also primes the tumor microenvironment for these immune checkpoint inhibitors. So there's a few trials I wanted to talk about today. So these clinical trials, the most kind of notable one is this Emerald one that was presented in January this year at ASCO GI, and essentially combined TACE with or without systemic therapy. And it was a large randomized double-blinded study. And then I'll talk a little bit about IMbrave 50, which is the other randomized study that was done in the setting of after resection, the adjuvant setting, post-resection or ablation for curative HCC. And then since this is a radiation symposium, I will briefly mention this study that we have that was done combining SBRT with sorafenib. That was a positive study. And then this launch trial, which was also a positive study combining lenvatinib and TACE. So this IMbrave 50 study was testing the efficacy of using our already pre-approved regimens, that is atezolizumab and bevacizumab, versus just actively surveilling patients who have high-risk disease and have surgically resected ablated HCC. And there was about 600 odd patients in this study, and it did show an improvement, pretty significant improvement in recurrence-free survival, but we still don't have the overall survival data that's awaited for this study. So this is the one that essentially might, kind of question whether we are ready for prime time in terms of combining these immune checkpoint drugs with local regional therapies. So this is Emerald 1 was this phase 3 double-blinded, large randomized control study of TACE with or without durvalumab, and then the other arm was using durvalumab with bevacizumab in unresectable disease. So this was essentially tested in patients who have child A or child puke A or child puke B7 disease. And this was a study design. So patients who were not amenable to curative therapy, they didn't have any extrahepatic disease, had a really good performance status, and no prior systemic therapy or TACE in these patients. So there were 3 arms, 1:1:1 randomization. The first arm was just durvalumab and TACE, and then they were followed by just received durvalumab alone, along with placebo. And then the second arm was durvalumab with TACE. And then these patients, after the first cycle of durvalumab, went on to get a combination of both durvalumab and bevacizumab. And then the third arm was essentially just TACE alone. And the primary endpoint of this study was PFS. So this is the PFS curves, essentially looking at the kind of the one that had the arm that had a statistically significant benefit. That was the combination arm of durvalumab and bevacizumab along with TACE. So the 12-month PFS was 55% versus 39%, and then the 18-month PFS was 43% versus 28% in the TACE alone arm. So this was a significant PFS benefit that was seen in this combination arm. However, the patients who received durvalumab alone along with TACE, those patients did not. There was no statistically significant PFS benefit in that subgroup. So this was the first global phase 3 study to demonstrate a statistically significant PFS benefit in a combined approach, combining immunotherapy with local regional therapy. The response rate were consistent across the clinical subgroups, and safety profile was manageable, consistent within kind of the known safety profile of both TACE and immune checkpoint inhibitor. I'll just briefly talk about these other studies that essentially don't use immune checkpoint drugs, but use lenvatinib or targeted therapy. that combined with local regional therapy. So this launch trial was a pretty large study in China, and patients were randomized either to lenvatinib or alone or lenvatinib along with TACE, and median overall survival was significant in this study, 17 versus 11 months, and PFS was 10 versus 6. Radiation with immune checkpoint drugs. But what we don't know is timing and sequencing, which is crucial for maximizing therapeutic synergy. When you administer immunotherapy before radiation therapy, that essentially aims to prime the immune system and releases tumor neoantigens. And then radiation by itself can modulate the tumor microenvironment and enhance the expression of these checkpoints that essentially are PD-1, PD-L1, and that thereby provides a kind of a primed environment to use these immune checkpoint drugs. So we know there's retrospective reviews, case reports, case series, there's some prospective data that have looked at association of SBRT and immune checkpoint drugs in HCC. There's this phase 1 study that was published last year that looked at safety efficacy of SBRT and immune checkpoint drugs in advanced unresectable disease. And this was only in about 57% in this phase 1 study. And then this was our TOG study that looked at combining SBRT with sorafenib. So not immune checkpoint drug, but there was a big randomized phase 3 study in patients with Child-Pugh disease that looked at patients who have recurrent HCC, unsuitable for surgery, ablation, or TACE. They were randomized 1:1 to either standard dosing of sorafenib, it's 400 milligrams BID, or they received SBRT with sorafenib at a slightly lower dose, that's 200 milligram BID, that was then increased after 1 cycle. Primary endpoint was overall survival. And there were about 290 patients. And the accrual for this study was actually closed early because the standard of care for systemic therapy had changed right around this time to immune checkpoint inhibitors. So overall, there were 190 patients that were accrued. It was a multi-site study. The median survival was actually improved from about 12 months with sorafenib alone to 15.8 months with the combined sorafenib along with SBRT. And then median PFS was also improved from about 5 to 9 months with SBRT combined with sorafenib. So yes, there was a benefit that was statistically significant in the combination arms. But the kind of big drawback of the study was that we don't use sorafenib alone anymore unless it's in the subsequent line setting. Ongoing trials kind of in this realm. There's a bunch of studies, kind of big phase 3 studies that are going on at this point. So this LEAP study, LEAP-012 study, is looking at kind of an interesting combination of TACE versus TACE with pembrolizumab and a combination with lenvatinib. So it's a TKI with an immune checkpoint drug and TACE. And then EMERALD-3 is this other kind of interesting study that's going on actually in the adjuvant setting. So post-resection patients receiving recurrent HCC receiving TACE with durvalumab and tremelimumab with or without lenvatinib. So this study has 3 arms. And then there's EMERALD Y90 study, which is going to be an important study looking at Y90 with combination checkpoint inhibitor and anti-VEGF therapy. And then the ROWAN study, again, looking at Y90 along with combined immunotherapy. So the standard of care kind of STRIDE regimen, which is durvalumab and tremelimumab. And then there's a study called REPLACE that's also looking at either TACE or TER with combined immune checkpoint inhibitor or regorafenib, which is another targeted treatment for HCC. So challenges that we obviously have to consider, that patient selection, who are the patients who ideally would benefit from combination therapy, identifying those patients, and then managing adverse effects from these combination treatments, and then obviously thinking about cost and accessibility in combining these treatments. So future directions, I think we're kind of awaiting a lot of data from this perspective of combination therapies with local regional systemic therapies for, especially for unresectable HCC. I mean, it definitely has a potential to revolutionize treatment for HCC and could alter the treatment paradigm in the future. But I think the most important consideration is the optimal timing for such combination therapy that remains undetermined. And obviously, what would be most helpful is if there's development of some precise like biomarkers and prognostic models that we may be able to select out the patients that would benefit from combined treatments. Thank you.
So we have some questions for Dr. McBride. What kinds of acute and long-term side effects of Y90 the patient may experience? How many times can the patient redo Y90?
So for the acute ones, for the acute effects, it's pretty similar to some of the other ablative therapies. It's that they'll get a post ablation or post embolization syndrome where they may have low-grade fever, have the overall with the lobar dose, if we were to give it to the lobar and we keep that under 120 gray. As the software gets better, we will be better at being able to calculate that. But with the cone beam CT, we're able a lot of times to treat tumor only or tumor and just a tiny bit adjacent to the tumor. So it's getting to be less and less to normal liver.
how is the total lung-grade exposure calculated? How do we justify the use of Y90 allowing whole lung dose up to 30 to 50 gray? Finally, is there any post-care dosimetry to confirm tumor coverage?
Okay, that's a lot of questions in one. All right, so for the first one, how is the total lung dose calculated? So when we figure out our either our tumor or treatment volume that we're going to treat based on our angiogram and based on and the MRI, we'll calculate that, and then we pick a dose, and then that sometimes we do a custom dose and sometimes we do a standard dose, but and then we plug into that spreadsheet the lung shunt that we got from the technetium study, and that will calculate our overall lung dose for each treatment. As far as how was 30 gray and 50 gray determined, I'm actually not sure of that. I know that's what's been standard the whole time that we've been doing yttrium-90 therapy, is that 30 for one particular treatment and 50 overall dose.
So I'm going to answer one question first. I think I deleted that one. There was a question asking that when I do SBRT lung, how do I do the liver constraints? We usually do 5 fractions. With 5 fractions, I limit the 700 cc less than 21. I believe people who are doing 3 fractions, they use the 700 cc or 800 cc less than 17 gray. So basically we usually use TG 101, and so that's my answer for that question. The next one is what is the mechanism of SBRT working with immunotherapy? You want to answer that one? You answer a little bit, and I will answer some of it.
So I mean, I think I talked a little bit about that, but I think what we kind of bring about this phenomenon called the abscopal effect every now and then. And when we talk about immunotherapy with SBRT or radiation in general, I think we've seen this phenomenon where you have kind of shrinkage of other areas when you kind of radiate one area, which is kind of very interesting, because I think what we know is, or what we've hypothesized is that there's release of these neoantigens when you radiate, and that kind of primes the environment for immunotherapy, and then you're like over kind of enhancing the expression of these like immune checkpoints, which allows us to effectively use the immunotherapies, and that's essentially. Anything you want to add?
So I agree with Dr. Christian's point. So I think radiation also can cure the we call the immunogenic cell death. So kill the cancer cells and then release another antigen, which will stimulate the immune reaction. And radiation also can cause increase the antigen presentation to the immune cells, which also can increase the immune reaction. And then the third thing, just you mentioned that it's a systemic immune reaction that which a abscopal effect. So, okay. Let's see. What is the future of immunotherapy? It's a combined therapy with local treatment in HCC. Yes.
So I think, we're still waiting overall survival data from that Emerald-1 study. And then there's these big, large studies that are still going on looking at other local regional therapies. So since we're, I think overall, I think the paradigm is changing to using more Y90 than TACE nowadays. So I think that would be a very important kind of study that, looking at Y90, particularly with these systemic treatments to see what the outcomes are. And then I think to some extent, we are in patients who have really advanced disease, advanced tumors, portal vein thrombosis, and unresectable disease, where AFP is really, really high. We always we've already started to think about these combination therapies. So we already sort of kind of use them one way or the other. Whether that's like right in conjunction with local regional therapies, or whether that's kind of a little bit far away, apart from the standpoint of timing between these treatments. But I mean, we've already started to move towards that in a way.
The last one, maybe with Dr. McBride. What is the mechanism? I have procedure working with immunotherapy.
Well, I think, we, probably the biggest one where we talked about abscopal effect is just one of the newer ones that we have is the ELIA device, or it's irreversible electroporation. That's probably the one that's been touted on the most, but this has been something that's kind of always the abscopal effect of, they're early on, and right after I trained, there were people who talked about not where patients had metastatic disease, not treating say a liver tumor entirely, but leaving a little bit of it with the idea that there'd be some normal tissue exposed to generate immune response. I mean, obviously that's a anecdotal thing, and certainly, but I think it's certainly an area of opportunity, and certainly we'll see how the research plays out in each of these therapies, both the Y90 and some of the other local regional effects.
One more online question, then we will go to the room. For Dr. Moon and Dr. McBride, how often and with what frequency do you do follow-up imaging? MRI or triple phase CT? Any issues with pseudoprogression?
Yeah, so as I think all of you are aware, and as there's a technologist shortage, and there's certainly a long wait time to get MRIs. So a lot of times for my initial follow-up, I will get a multi-phase CT if it's suitable, but I prefer to get an MRI about every 3 months. We kind of, going with the tumor board, if it's been stable for usually maybe 9 months to a year, then we might change our intervals to say 6 months, and then hopefully, if we have a patient who's doing really well, is that we go back to their usual screening for a cirrhotic patient yearly. There are issues with pseudoprogression. I'm not sure that so much as, but there's enhancement that can last for a long time after treatment, and we just have to monitor. It's kind of a combined process. The hard part is that we have a lot of patients who are coming from far away, so they want to get their imaging done locally, and the local people aren't going to use the same MR protocols that we are here at the med center, just because they may not have as new machines, or they just might not have the same body radiologists who are doing it. So like things like subtraction images and things like that are very helpful for us to determine if there's any residual tumor. A lot of those things aren't done at some of these smaller areas, and it can be challenging.
So for post-radiation follow-up, I do the same thing every 3 months, at least for a year. And if everything is getting better or smaller, then I will change to every 6 months. I also prefer MRI. Maybe the first several times I do MRI, and then if there's no change, and I change to CT. For pseudoprogression, actually, after radiation, we probably see more like enhancing than you guys doing it. So also a lot of patients, they don't give you the shrinkage immediately. I have a patient actually after a year then start to shrink. So you have, as long as they are not growing, I'm okay, just keep watching them. Any other questions in the room?
Couple questions for Dr. McBride. So I'm just curious, what's the pattern failure after? Is it failure in the center, is it failure in periphery after EH90? So that's my question. The second question is, when you have several tools in your toolbox, you have FRA, you have EHM, you have a TACE. How do you select patient?
Yeah. Both good questions. I would say that the failures tend to be in the periphery, not in the center. There also can be in those patients when it's just hard to find the vasculature to an area and you feel hesitant to do an ablative technique, like say we have a lesion that's really close to the heart. We, tend to, just because even under ultrasound, we get, we're putting these large probes, if it's a microwave probe or a cryoablation probe, we don't feel very comfortable getting those close to the heart in a patient, who's awake. So we tend to use Y90 in some of those areas on smaller tumors just because of the location. And sometimes they can be, for a small tumor, sometimes could be difficult to target that vasculature. As far as how do we determine, ablation versus chemoembolization, it's really a patient by patient basis. There was for a while we were doing a lot of combined chemoembolization and ablation just to make sure we got the periphery, and we still do a fair amount of that. But as the technology has come along with our imaging, we're doing more with Yttrium-90. And we also, one thing that we do here that a lot of other places don't do is we do a lot of cryoablation in the liver. I think it was mainly because early on we just had the unfortunate of having what seemed like a large number of complications with microwave, and really can't put a pin on that and why. Because if we look at other institutions, they don't do nearly as much cryoablation in the liver as we do. And that was just a way our practice evolved. And so what's nice about the cryo though, is that you can watch the ice ball. And so you can see that you got the whole tumor or that you're getting close to something. Say like, I've got a patient who's got a lesion right next to his gallbladder. And so so we've, I did a combination when I went on his follow-up where I did alcohol injection directly, and then I followed that up with some cryoablation. I don't know that it necessarily is. I think that we like the technology just because, again, we can visualize the ice ball during the procedure. And whereas if you do radiofrequency ablation or microwave, you have to just trust the manufacturer that if you turn it on for this long, this is what you're going to get. Whereas with a cryoablation, if you get that tumor down to -.
Do you guys have any thoughts which way might be better? Combining the SBRT with immunotherapy versus combining radioisotope with immunotherapy?
Radioisotope, the only difference. The only different radioisotope and the external beam radiation, what's different? One is more focused, right? One is the radioisotope you are talking about, Y90, right? In this case. And SBRT. Combined with immunotherapy, which one is better? Is that what you're asking?
Yeah, just basically two different type of radiation combined with immunotherapy. Which one is possibly a better one? Just want to pick your brain because I have something in my brain, but I don't know whether that's correct or not.
I think that's probably the question from there. They keep asking the mechanism, why you do this one, why you do that one. Y90 will do that. And then for the microenvironment, radiation can work on the tumor microenvironment, can cure the maybe T regular cells. Those very high dose probably won't do that. So, hey, see that? I think SBRT is better. And then the radiation SBRT probably also can work with a checkpoint inhibitor, increased checkpoint inhibitor, right? So effect. That's all I can think of. Why don't you talk about it?
No, well, I think that, I mean, you present a really interesting question, but I think if that's, you know, if the, yeah, I think the idea with doing Y90 traditionally has been to get as high a dose to the tumor without putting much dose to the liver as possible. If we're intending to combine with an immunotherapy, we may find that it's better to give a lower dose. And maybe we don't have to get as selective, just because the angiograms get tedious, and you know, you certainly, it's something that, you know, you have to be more advanced angiographer to be able to get these catheters in. Sometimes, like, you know, I did one yesterday where, you know, it's this tiny little segment 5/6 tumor, and I gave a dose of intraarterial nitroglycerin, just, you know, so I wouldn't get any spasm of the arteries or whatnot. So there are some methods that we have to do to get these small catheters, just like we do when we do prostate embolization, that we're trying to get these things into little tiny vessels without causing them to be damaged. If we damage the artery supplying tumor, then we can't treat that day. So so that, you know, that might be something to think about it with the combined therapies.
What about the other way? Immunotherapy will affect the RP or
So yeah, I mean, I was gonna say, so I think what I mean, we obviously don't do this a whole lot, but if somebody was like a really advanced HCC, you know, portal vein thrombosis, has maybe something that looks like has a bony lesion and has like a very, very high AFP. I mean, we like to start them on systemic therapy nowadays because, you know, we have really good treatment options, and, you know, you don't want them to go waste, and, you know, it's too late to use those treatments. So, you know, I feel like we're using them much earlier nowadays. But I think what I have maybe observed a couple of times is, you know, when we do combine these treatments, sometimes, you know, you see kind of an exaggerated immune response, and some patients actually have a kind of a grade 3, like immune-related adverse event. I don't know necessarily, obviously, we don't know whether that's really because you're priming the immune system so much, you know, to begin with these, like, you know, local regional therapies that you're, you know, causing that. Or is it really that could have not been avoided in the first, you know, it's hard to know. But I think what was interesting in this thing I wanted to mention was this Emerald study, that TACE one. The patients who got immune checkpoint inhibitor alone actually did not benefit when combined with TACE. It was only those patients who also had like a bevacizumab added. So they had Avastin, and they had immune checkpoint drug, and they had TACE. All those three things combined is when they actually saw a PFS benefit in these patients. The other arm, there was no PFS benefit. So it's like really questioning, is there truly a benefit of using immune checkpoint, or, you know, is that just kind of revascularization and, you know, kind of your the Avastin, it was what was doing the job there. So, you know, again, I think the kind of data that's coming forward will tell us a lot more about these combinations.
That's a great lecture, but it didn't answer the question. I don't have a clear understanding, but I guess the reason I'm asking that is we're trying to design a gamma tau trial for brain mets with immunotherapy, but we were hoping to justify why that kind of radiation would stimulate immune response even more, Right, because if you do SBRT, you still low dose showering a big amount of liver. Even we're talking about the very high dose focused. So you're gonna change the non-tumor area of the immune cell infiltration significantly, particularly the Cooper cells, those macrophage in the liver, that eventually will have a long-term consequence. Depends on how they get depleted and how the new ones come in. And but Y90 probably have less a problem like that. But at the meanwhile, you're damaging the vasculature way more than SBRT using the Y90. So that's a double-edged sword, because you're damaging the blood supply, but you're also cut down the blood supply.
So you have to believe Y90 really focus.
Well, since it's short range, even if diffuse into other areas, not gonna deplete all the environment. Right? It's gonna affect surrounding area in close range, and those immune cells moves. So you're not gonna deplete them by delivering the dose within days. But SBRT is different. In minutes, the cells cannot escape.
Okay, thank you. See, he answered for you.
Yeah. But I would support your SBRT trial.